Hello, everybody. Welcome to this 1 hour introduction to the autonomic nervous system and applied clinical neuroscience. The autonomic nervous system is one of the foundational pieces, I think, when you're looking at the nervous system and at how we assess the brain and nervous system, because it's something that we use as a gauge for everything that we do. Your autonomic nervous system, by way of thinking, is automatic, right? It's things that are done in the background, things you don't really have to think so much about. And as applied clinical neuroscientist or functional neurologist or chiropractic neurologist, whatever name you like to use, brain-based neuroscience or brain-based chiropractor, we use the autonomic nervous system as a gauge to how you're affecting the nervous system. Because as that automatic piece, it has a lot to do that you don't necessarily consciously think about. So it's the one thing that we can measure on you that you're not able to change or alter. And as we go through our different courses and the different lectures, if you've heard me speak before, we talk about and we use this as how we look at the nervous system. And that's what I really want to give an introduction with this class is just really how we look at the system, how it's different maybe than other healthcare professionals, how we apply a different lens with which we look at the body and disease and physiology, maybe than some other professions. And so as we jump into this, we'll go into unveiling that the thought process behind applied clinical neuroscience, and we're really going to look at it through the lens of the autonomic nervous system and how we use that to understand how fragile the nervous system is, or how excited or how depressed the nervous system is in different ways. Because it's important to know that if you're applying therapies, how are you adjusting or how are you changing the physiology? Because at the end of the day, that's really what we're talking about here is how we're adjusting physiology to move further away from disease or further away from disorders of physiology is how we often refer to it. So if we jump in here with this, first, a little bit about who I am for anybody who doesn't know me. I'm a chiropractor first with advanced training in applied clinical neuroscience. I have my diplomate in functional neurology, the developer of the Life University Certificate of Applied Clinical Neuroscience. And it's a 100-hour program that we teach through Life University in Georgia and then also over in China. I'm also a board member for IAFNR, the International Association of Functional Neurology and Rehabilitation, and then owner of the Brain Optimization Institute in Jacksonville, Florida, where I work with my wife. And we do some weird things. We often say we're kind of polar opposites in the way that we approach things. So I think our clinic is unique in that. I'm very much the science guy. I need a research project or five to support anything that I'm doing. My wife is on the other side of it. She's more into the feels and kind of feeling through her way of doing things. There's research behind both, is the reality of it. It's just a different approach in the way that we look at things at our clinic there. Also, the author of Never Accept Your New Normal. This is really my why I do what I do, why I'm in chiropractic, why I ended up, as I jokingly say, taking the blue pill, going down the rabbit hole and researching as much as I could in neuroscience around chiropractic because of what happened in my story and just kind of a brief understanding there, because I do think it sets the tone for where we go with the rest of the things that I teach. When I was in high school, I was paralyzed from a football injury. I was hit going out to catch a pass and kind of twisted down in an awkward way. And I actually finished the game. Actually had one of my best games playing that day. And I finished the game. That was a Thursday night. I was JV. I was a sophomore, so we played our games on Thursday nights. And I went home, had some pain, had some soreness, but I took some muscle, pain medication and I was okay. But Friday I went to school, was doing things with my friends Friday evening, and I had some tightness in my chest. And I went to the hospital, and they diagnosed me with a pulled muscle and an out of place rib, gave me some muscle relaxers and some pain medication, some more pain medication. And I woke up the next morning and I couldn't feel or move anything from about my nipple line down or my chest down. And obviously, at 15 years old, it was earth shattering. And when I first got to the hospital, the doctor who met me there, brilliant in that he diagnosed me within seconds with a safety pin and a black magic marker. He knew kind of right where the lesion was after I sat in a different hospital for hours. But then he walked in my room about an hour later and told me that I had a spinal stroke and that I'd never walk again. Thankfully, he didn't know what he was talking about because I walked out of the hospital a month later, and long story very short, it was another year after that, a little bit better than a year after that, that I received my first chiropractic adjustment. And even though I walked out of the hospital after, a month, I still didn't have all of my sensation. I still didn't have pain and temperature and those things from that nipple line area down until, again, a year afterwards, I got my first adjustment. And I went home that night and I kind of was making a shower, getting ready to go to bed. And I realized that I put my foot in the tub and it was too hot. And it kind of startled me at first because I wasn't used to being able to feel temperature like that in my lower extremities. And so that was, the adjustment that kind of changed my life when I went to school trying to research why I had the effect that I had and why, if you look at the original chiropractic story with Harvey Lillard, why he had the effect that he had in that restoring of hearing. And what I came to was with the understanding of neuroscience that what we do when we adjust is we're affecting the brain. And now there's a ton of research and science behind that. If you look into what Heidi Havik has done in New Zealand, what Stephanie Sullivan is doing at Life University, they've now proven that what we do with the chiropractic adjustment is actually affecting the central nervous system and specifically the prefrontal cortex and the cerebellum, which are two pretty important areas of the brain and nervous system when we're looking at things. And we'll dive into how the frontal lobe and how the cerebellum really integrate within that autonomic nervous system as well, because they play a big role in this, in what we're looking at. So, as we look further into this, again, we said this at the top with applied clinical neuroscience. It's a lens with which we look at the system. I often say that in traditional Western medicine or allopathic medicine, they are really good at looking for pathologies. They're really good at running imaging like an MRI or a CT scan. Sometimes there's lab work, and they're really good at assessing if there's something pathological going on, meaning, is something bleeding that shouldn't be bleeding? Is something growing where it shouldn't be growing? And they're good at finding the way that that looks. They're less good at picking things up early on when we can maybe still do some things to prevent it. They're also less good at seeing disorders of what we refer to disorders of physiology. And I love the history of our profession with Dee Palmer. Again, just a real quick history lesson here. Dee Palmer was the guy who invented chiropractic, and he used this word called tone. And he used another term called dis-ease, is how he referred to it. And he said, and I'm going to paraphrase this by a lot, when you have a decrease in tone, you end up with more dis-ease. And this was over 100 years ago now that he was saying this. Well, now in the literature, you could interject tone with central integrated state or neuroresilience. And what that means is what Didi was looking at was the overall attitude of a thing, right? Is what tone means. And what he saw was when things had low tone or low energy, if you will, they were closer to dis-ease, or what now, again, in the literature, we would refer to as disorders of physiology. And it's the precursor to those pathological findings. A great way to look at this is like something like Alzheimer's disease. They say now in the literature that you have Alzheimer's for about 15 years before you show the first outward signs and symptoms like really poor memory or poor emotional regulation. You actually have that disease processes developing for about 15 years prior to that. And there are little things that we can pick up on that we can test that show you're headed towards that disorder of physiology. And ultimately, then that pathological finding that would be Alzheimer's or Parkinson's or any of those neurodegenerative conditions. And a lot of our conditions are like that. Another really good example of this is in the US, you can't diagnose autism really until 5 or 6 years old. Yet there's two tests that you can do on a 6 month old that have about a 95 to 98% likelihood of being diagnosed on the spectrum if they fail those two tests. So again, there's disorders of physiology. We have the ability, and I think as applied clinical neuroscientists and as chiropractors, we do this well. Chiropractors are used to putting their hands on people and kind of, getting in there, feeling things, palpating, however you want to talk about it. And we're really good at understanding and feeling how much tone there is in muscles, right? Well, that tone that there is in muscles applies to that tone of the nervous system as well. So when you feel things that are just a little low tone, right? Like babies, another really good example. If you've felt enough babies and you've held enough babies, you'll hold one that just doesn't quite feel right, right? Either they're hypertonic, which we've had a lot of that recently with babies, and you see that in things like CP and hypoxia type issues, or they're really hypotonic. They're just kind of floppy. And you can feel that tone of the muscles of the body. And really, what that is that you're feeling is that tone of the nervous system. So, Didi used the term tone. And now in the literature, it's that, again, that neuroresilience or central integrated state. And what that means is it's just low firing of the nervous system. It's a decrease in overall energy or the overall attitude of the nervous system. And with applied clinical neuroscience, we get really good at picking up those low tone spots in the brain and the nervous system in the body by getting really good at honing in on our observational skills, looking at the eyes, how we look at pupils, how we look at how the eyes move, how we look at posture, how we look at your movement, how we look at your affect. All of those are clues as to the overall tone of the person or patient sitting in front of you. And so when we talk about this lens that applied clinical neuroscience is using, we're using that lens to look for tone or disorders of tone or dysfunctional tone in the system. And we do it in a way that, again, is just a little bit different than what other healthcare professionals have done. And because we look at the system a little bit different from the lens that we use to look at it, we develop therapies that are kind of unique and cutting edge in how we apply change to those people. And in doing so, we've been able to make some changes in populations that hadn't gotten anywhere with other, traditional healthcare methods or other practitioners. It's not uncommon for me or my colleagues to have a patient walk in literally with a grocery bag of medical records and say, "Hey, they told me this is as good as I can get. What can you do?" And, really that's where the book that I wrote came from. My new normal was supposed to be in a wheelchair. And in, a little better than a decade of working with patients, I've had a lot of patients whose new normal was supposed to be pretty dysfunctional. So my mantra, because I've seen myself not only do miraculous things, but I've seen patients do miraculous things as well and get over things that they were never supposed to have gotten through or gotten over. I've seen babies do things like crawl and walk and talk and sing on stage with their dad, who's a traveling pastor, that was never supposed to really make it all that long. And so I never accept your new normal as a patient. I never accepted my new normal as a patient. And I think as doctors, it's our duty to keep looking and educating. And if we're not the answer, find somebody who is, right? But I think there's always something out there that can be done. There's way too many scientific breakthroughs that happen on a regular basis, especially like we can get really weird and talk about frequency medicine and matching tones and matching frequencies and numbers and kind of go down the rabbit hole on that. And we'll do some of that in other lectures. But there's a lot of things out there. There's always something that I feel can be done. So again, my mantra that never accept your new normal, there's always something else or a different lens that we can look at things through. And as we unfold this class and other classes, you'll get the gist of that. And we'll show you how to look at things differently, but also how to build treatment plans that approach the person, the patient, the pathology, the physiology, however you're looking at it, approach that differently as well. So it comes down to this. Your brain has three jobs. And as a neuroscientist, as a chiropractor, as a clinician, our job is to look at how well your brain and nervous system is able to do those three jobs. Now, this is a gross oversimplification, right? I mean, we can really dive into your brain does a whole bunch of other things. And again, in other lectures, you will definitely get into that. But at the core of it, your brain has three jobs. First, it has to perceive the world around it. It has to use all of the receptors that you have in your body, your touch receptors, your photoreceptors in your eyes to take in light, your hair cells in your ears to pick up sound and movement with the vestibular system, right? So you've got all these receptors that are all over your body, and they're intended to be there to perceive all of the different sensory stimuli that your body can perceive. Now, something else is, and I always love this, the electromagnetic spectrum, if it's the size of your screen, you actually only perceive about a hair of that. Again, depending on the size of your screen, it could be bigger or smaller than a hair, but you only perceive about a fraction of that. There's a whole bunch of other things like microwaves, gamma rays, radio waves that we don't actually have the ability to perceive, but are out there. And believe it or not, they do bind to some of your receptors, or they do affect change in some of your receptors. So the perception part is for the most part done by your receptors, and then it's sent through the sensory system through the cerebellum, which does unconscious sensory perception, and into the cortex, which is where your conscious sensory perception happens. And you can have a breakdown at any point of that, right? And you can have an overflood of sensory, you can have an underflood of sensory, where you can get too much sensory input or not enough sensory input. Another great example here with this one is you take a kid that's on the spectrum, like a kid with autism, right? Um, One of the thought processes is they don't have a real good filter. The way I usually describe this is all of your receptors are always going off. It's your brain's job to filter out what's important, right? Like, for instance, if you're sitting watching this, the receptors in your butt are going off. They're perceiving the chair or the couch or the floor or whatever underneath you. But until I said the word butt, you didn't feel your butt. But now that I said butt, all you can feel is your butt because we made it conscious. I said that word and your brain said, hey, I better check in with that area and see what's going on. So then you were able to perceive that again. There's a thought process with kids on the spectrum that they don't have the ability to filter that out. So they're always feeling their butt and their feet and the hair on their head and the shirt on their back and all of those other things. And they're overloaded with sensory input all the time. That's again like sensory processing disorders. They get bombarded by that sensory input. And so they do the self-stimming and they actually think of it as their body, they're checking in with their body, right? When they're rocking. That's how they know where they're at because they're actively perceiving that movement at that time so they can consciously perceive that. It makes them feel more comfortable. You see it a lot with kids. They're walking down the hall and they got their hand out. They're feeling the wall as they go down because they don't actually have the ability to perceive barriers any other way or to lock into where their body is in space, right? So that perception can break down in a lot of ways, is what I'm getting at. You can have a problem with the receptors themselves. You can also have a problem with the different areas of the brain and how they perceive that information. Once you perceive that information, you've got to process it. This is the one where it gets pretty convoluted. There's a lot to the processing part, right? All of your information comes in through the back of the brain and then it's kind of reacted to with the front of your brain. So, and you have to process all of that information in between. Now, processing isn't only taking the signals that are encoded for in those receptors, like your photoreceptors see light, but if I push on it, I can mechanically activate that too. So you've got to process how was that receptor activated. But then you also, your limbic system, that's where your emotional system and that the deep parts of the brain come in here too, as part of the processing, because they're going to take all the past experiences that happened and they're going to overlay information on top of that as well. So now you got to perceive and then you got to process and assign value to that system and say, is it important? Is it something I need to run away from? Is it something I should run towards? Is it something that's gross? Is it something I really like or I enjoy? There's all that information that goes into that, right? So we perceive, process, and then the last piece of this is we form a reaction. Now, this is the part, again, when we get into cerebellum and vestibular and other areas with other lectures, we're going to get really into the reactions as well. And we'll get really into all three of these pieces in separate ways. But the reaction can be a movement, right? It can be literally moving away from the thing. It can also be a thought, what you think about the sensory input that was just put into your system. Or it can be a cognition or a reaction mathematically or verbally to what it is that you're experiencing from a sensory perception point, right? So you can have all three of these things going on simultaneously at the same time and with different sensory stimuli. And you can also have a breakdown in any one of those three things at the same time. So this is where it gets to be, we can simplify it. These are the three things. Essentially, that's all your brain has to do. Perceive the world around it, process that information, and then form a reaction to it. But it can break down in so many different ways and on so many different levels with each of these things. And your world does it to you, right? If you take something like this, for instance, um, just that by the way it uses color and shading and light, it can give you the perception of motion. There's actually no motion happening here, but if you're looking at the screen here and you're watching the balls or the blue spire with the circles on it or the green background, because of the way it's shaded and because of the way that it's colored, it actually gives the brain the perception of movement. Same thing with something like this, right? So there's there's ways that the environment can play tricks on you, and you can start to perceive that these circles are actually spinning, and they're not actually spinning at all. None of them are spinning faster than the other, although you get the perception that the ones that are in the middle are spinning faster because they're smaller. But the way that, again, that it's shaded, the use of color and light, and the use of how they mess with the receptors in your eyes gives a perception of motion with this, right? So again, this is just one aspect of perception that can be altered. Magicians use this to their advantage all the time with every magic trick that they do. There's also the idea of emotionality that comes into this, right? So this is what's called a Rorschach painting, and it wasn't too long ago that they used these to, depending on what you saw in the picture, they use these to determine your psycho-emotional state, right? So you see somebody screaming in this picture, or you see a butterfly, or you see a bat. There's different things that you can perceive in this. It gives a clue as to how you're doing mentally, how you're reacting to the world emotionally, right? And then there's also just your perception or your point of view that can give a different skew to how you're perceiving things, right? In chiropractic, we're really good at this, the ICA and the ACA, and looking at the same thing and seeing two totally different things. But you can have that skew of perception based on where your view is coming from, right? If you're a sports fan, this is huge. Anytime they go to replay, they got like three different camera angles on the same play. And one camera angle might show that it was a first down in football, and another camera angle might show that it was not. And so based on your perception and how you're seeing or triangulating your view, you can have a completely different understanding of the world around it, right? And exactly, and know for sure that that's right or wrong, because you're then going to take that perception, you're going to go into previous emotionality with it, you're going to go into previous experiences, all of those things overlay it, and then you can actually become emotional about it as well. So, a lot of things can alter that perceptual understanding of the world around you. So, as doctors, then, as clinicians, we need to get really good at finding what's going on. We often say when we teach this, and we'll go into this in depth with different programs, your exam, it starts in the waiting room, because as soon as you get into the exam room, the patient is lying, essentially. And what I mean by that is they're not doing it intentionally. They're not lying to you like, oh, I'm going to trick that doctor or something along those lines, but they're there for a reason, right? And they're being tested. People inherently want to do well when they get tested. So we need to be really good at finding the LLL. And this is a term that you'll hear throughout different courses if you hear me speak, or Dr. Hall, or a lot of my other friends like Dr. Vestal, Dr. Federley. Is looking for the LLL, or longitudinal level of the lesion. Just because we're brain guys and we go to nervous system doesn't mean there can't be a problem with the end organ or the effector, right? It doesn't mean there can't be a problem with the muscle, right? A muscle would be a good example of an end organ. The heart would be a good example of an end organ. As we get into the autonomic nervous system, you can have a problem with the heart, or you can have a problem with the autonomic nervous system. Both of those things can be true, and it can cause a change in heart rate or respiration rate at the same time, right? And it can be either one. So we have to be really good at, is it a heart problem, or is it a nervous system problem, or a control issue? And then there can be a problem with the receptor, right? You can have things like myasthenia gravis, where there's a problem with the receptor. Type 2 diabetes is another great example of a receptor-based problem. You can have a problem with the peripheral nerve. You can have damage, and we'll go through the different classifications. You can have a problem at the spinal cord level, at the brainstem level, or the thalamus. The thalamus, again, is where that sensory filter is. So if we go back to the example with kids on the spectrum, it's a problem with the thalamus or the thalamic issue. You can also have a problem with the cerebellum, which is responsible for making things smooth, pretty, and coordinated. Or you can have a problem at the cortical level, and the cortex is that area that really processes everything and then understands it. That's where nausea happens, essentially. So we jump into a little bit more specific with this, right? So end organs. This is a list of them. You can have a problem with the heart. You can have a problem with the lungs. You can have a problem with muscles or joints or bones. Any one of those things can still be the problem. You can have a broken bone, right? You can be feeling pain in your leg because there's a fracture. Or you can be feeling pain in your leg because of a central processing disorder, something like CRPS, or a condition along those lines, right? Chronic pain syndromes, fibromyalgia. It can be a problem with the body, but it can also be a central processing disorder. A great example of this one with the heart, specifically, is a patient that I had. Her name was Noreen. And she was, I forget the exact age now, she was probably 65 or so when she came to us. And she had had dizziness issues. She had trouble when she would stand up. She'd get really dizzy, just about pass out. And this is a woman who wanted to go hike to Machu Picchu in Peru. And that's a huge undertaking for someone who gets dizzy just standing up and at 65 years old at that. And so what we found is we examined her and she was overweight. She was, we'll say 60, between 60 and 65 years old. And she was overweight, not obese, but she definitely was ahead of her target weight. But sitting in front of us, she had a resting heart rate of 65 beats per minute. Now, she went to a cardiologist. She actually went to a couple of cardiologists, and they said they didn't look to the physiology. They looked at the pathology, right? They said there's this woman sitting in front of us, a normal heart rate is 60 to 100 beats per minute. Hers is 65. She must be good. And they sent her out. They didn't do much more testing. They put her through a really mild stress test. We found out later that she was able to pass for her age, right? She passed it for her age. Um, but when she's sitting across from you, and it's a 65 year old woman who's out of shape and she's got a resting heart rate of 65, your spider sense should be going off. Now, she went to cardiology, they ruled out the heart. So now I'm into this is a control center issue, or maybe it is still heart. And what we actually found out with her, we sent her to a cardiologist that kind of knew what they were doing. Not that the other ones didn't, but maybe they didn't. And she was actually diagnosed with congestive heart failure. And they put a pacemaker in her fairly quickly after we got her to the right doctor. But it took us having to sit there and say, I know your heart rate is in the normal range, but it doesn't fit your body type. It doesn't fit your presentation. We had to look at it with our lens of does the physiology match the person that's sitting in front of us? And it didn't. So we were able to find that end organ issue actually because the nervous system was working appropriately. The nervous system was doing what it was supposed to be doing. The heart was struggling to pump blood, so it decreased the heart rate because it was in congestive heart failure. It didn't want to blow a stroke or blow an aneurysm. So her body was actually adjusting appropriately, but the system was broken. So we can look at things like the heart, we can look at things like the lungs, we can look at things like the muscles. We cannot rule those out as we go through this process and as we find out where the issue may lie. Again, receptors can be the issue too. We talked about a couple of these. Myasthenia gravis is a great example of this. If you've got somebody who's developing weakness over time and they're weak later, it could be the acetylcholine receptors on the muscle, right? The ACH is what binds at the neuromuscular junction and causes a muscular contraction. Well, if they don't break down acetylcholine esterase, which is what gets acetylcholine out of the cleft, and you end up removing too much acetylcholine, now you can't cause a muscle contraction. You end up with weakness and issues along those lines. Usually you see it in facial muscles or small muscles first, but it's a problem with the receptor, right? It's a problem with the receptor, and really it's a problem with the enzymes that are breaking down chemicals in the synaptic cleft or at the receptor base. You can also have type 2 diabetes is another great example of a receptor problem where you overflood the insulin receptors. They're no longer sensitive. So now the insulin receptor no longer binds insulin. So you can have a insulin sensitivity or type 2 diabetes. Sensory neural hearing loss is another great example of this. The hair cells in the cochlea where we perceive sound, they can actually start to break down and we can no longer be able to hear again. So again, it might not be a brain problem that the tinnitus is coming from, but actually with tinnitus, they actually say it is probably a neurodegenerative condition, an early sign of a neurodegenerative condition. But you can also have that sensory neural hearing loss. That's the hair cell actually dying, that's decreasing the activation of the brain. You can have peripheral nerve lesions as well. This is another great example. If they can't feel their fingers, is it a stroke or is it a peripheral nerve issue? We've got to be able to go in and understand Is it a breakdown in that peripheral nerve? And then once you find out is the peripheral nerve, is it coming from the neck? Is it coming from somewhere else, right? This is where in chiropractic school we were really good. We got really good at determining where the level of the lesion was if it was a peripheral nerve thing. And we'll go through some of those things as well as we kind of diagnose how to pick that up. But there's different levels, right? You can have Seden's classification is the one that I go to most of the time with neuropraxia, which is a class one. It's a very minor injury. The endoneurium, the perineurium, the epineurium, they're all intact. So there's no actual damage to the nerve. There's just think of it more like bruising or compression that causes a decrease in blood flow and electronic flow through the nerve for a little while. This is you slept on your arm wrong or you slept weird and you wake up and your hand is kind of tingling, you shake it off, kind of move it around for a little while, the feeling comes back. That's an example of like neuropraxia. A level two of this would be like accent nemesis, where the perineurium and the epineurium are intact. Um, this is why peripheral nerves regenerate. This is where you get Wallerian degeneration distal. So with those two being intact, you still get some dying of the endoneurium, but you get Wallerian degeneration. So the nerve actually lives off of the degeneration to regenerate. And your peripheral nerves, we know in accent nemesis, they can regrow about 1 millimeter a day. Um, the same is true for neurotmesis, which is a class three, which is a partial, or it can be a complete lesion of the nerve, but you still have that Wallerian degeneration that's occurring, and the nerve can actually regrow again at about 1 millimeter a day. There are some interestingly cool techniques and other things that can speed that regeneration up. Some research has shown as much as 3 millimeters a day with certain types of equipment to regenerate some of those nerves. More things if you get into Seden's classifications, first degree, second degree, third, fourth. It's just a little bit of an expanded version of Seden's classification. My suggestion would be find one of these two, get good at understanding it. Seden's is easy, it breaks it into three easy parts, right? You can also have lesions at the spinal cord level, and this is what had happened to me, right? They diagnosed me with a spinal stroke, which looked like D here with the central cord lesion, right? It was everything below that. They were wrong. What we came to find out is it was transverse myelitis. Actually, sorry, it was A is what they had diagnosed me with, was a transverse cord lesion. Um, with a spinal stroke, but it turned out to be transverse myelitis, which is an inflammatory process. But again, we'll go deeper into this in other classes, but just know that the spinal cord level can be a breakdown as well. You can have issues with posterior cord where this is a little blue guy here, where all you lose are things like vibratory and position sense, your accurate sensory input, because that travels up the dorsal columns, that accurate sensory input. You can have a central cord lesion, which is C, which is like a syrinx, which is that uh, classically thought of in test questions as a cape-like shawl distribution, where you get that loss of pain and temperature in that cape-like shawl distribution, because usually you get your syrinx at about C6, and that's what you're seeing with the green there on the outsides of the arm. So there's different classifications that we can have based on how or if the lesion is in the spinal cord. Hemicord lesions are really popular, like what's called a Brown-Séquard lesion, where you get pain and temperature on one side, and then sensory and accurate sensory and motor on the other side, and it's because of where those pathways cross. And again, as we get good at diagnosing this stuff, we'll talk about where these levels have to be based on what your findings are. Other things that we can have a problem with, brainstem or thalamus. We talked about the sensory filters there at the bottom. That's the kids on the spectrum. Your pattern generators are also in the brainstem and in the cerebellum. When you get somebody who's supposed to have a good cross crawl, right? Opposite arm and opposite leg lift together. When you have a breakdown of that, that's in the anterior cerebellum and can be in the brainstem. Other important pattern generators that are located in these areas, things like heart rate, respiration rate. When we get into autonomics, we're really going to get into talking about this part of the brain specifically because when you have a breakdown in those areas, you have a breakdown in a lot of things, right? So things like stroke, locked-in syndrome, your integration centers, all here in the brainstem. Cerebellum, one of my favorite parts of the brain. It balances and coordinates everything. As we get into other modules, we'll get really deep into cerebellum, as we get into cortex. And I say the cerebellum is one of the most important parts of the brain, and then we throw a slide like this in here. Um, the cerebellum has more connections and more cells than anywhere else, but you can actually survive without it. If you look at these two pictures, the bottom picture is a normal brain and nervous system with the cerebellum there in the bottom. And the top one, you see that big black hole is where the cerebellum is supposed to be. And this one, when you read this research article, this person, it was actually, they kind of refer to it as an incidental finding that they didn't have a cerebellum. The truth is, she had nausea and balance issues growing up as a kid, but um, she was able to walk by age 7. There were some obvious developmental delays and things like that, but they found that she was missing a cerebellum kind of coincidentally. They just thought it was a developmental delay. They hadn't done an MRI because it was a little kid, but by age 7, they MRI'd her and found that she didn't actually have a cerebellum. But that's the beauty of the brain and the beauty of neuroplasticity, and why we do what we do is, even though the brain may be missing a crucial part of it, it still has the ability for other parts to rewire and take up some of that function in the absence of that, right? And that's why I never accept your new normal, because your brain has the ability to do stuff like this from cradle to grave. What we know now is that we thought babies just had neuroplasticity. Now we know you have neuroplasticity until the day you die, right? Other things that can be a part of that longitudinal level of the lesion, the cortical areas. There's areas like frontal, temporal, parietal, occipital. Your insular cortex also does quite a bit. And we can look at all of those as being areas of the lesion, right? And so, as doctors of applied clinical neuroscience, we need to get really good at how we assess those longitudinal levels of the lesion and how we can find out what's broken and what's not, and where to start, right? Because if you get really good at finding where the main problem comes from, then you can really tailor your therapies to that. And there's what we'll call upstream and downstream effects of things, and we'll talk about what all that means as we go deeper with other classes. But you can tailor your therapies based on where that LLL is, or where that, what we call the NPD, neurophysiological delineate, in what area is not functioning well. And I won't say broken because oftentimes it's not going to be a pathology. Oftentimes it's not something that'll show up on imaging. Concussion is another great example of this. It doesn't necessarily show up on imaging, but there's a bunch of neurophysiological delineates there, or breakdowns in how the system functions, or breakdowns in the efficiency of how the system functions. And so if we get really good at being able to pick these lesions out, we can get really good at then applying therapies to those areas. And again, we can get results, we can get changes in the brain where other professions that don't look through the same lens have not been able to get changes and not been able to get results. So when you get really good at this, you get really good at becoming a doctor of physiology. And that's essentially what we're talking about is you're an applied clinical neuroscientist, you're an applied clinical physiologist, because you can alter neurophysiology and body physiology in ways that other people can't when you get really good at this. And this system, the reason I love to do this one first in any, lecture that I do, is because this system is kind of the key to that. The autonomic nervous system is it's the foundation. It's the automatic part of how you do everything, how you move blood, how you move nutrition, how you digest your food. All of that comes into how you utilize energy, right? And if you don't utilize energy, you don't go very far. You don't utilize energy, you don't create any tone, you don't create any neuro resilience, and your system then starts to suffer. Dee would have called it low tone. Now we would call it a poor central integrated state, or a lack of neuroresilience, or you might have a neurodevelopmental delay, or a neurodegenerative condition, or insert whatever pathology you want to talk about here. But understanding this autonomic nervous system is key for, one, what's the tone of the system? But two, am I applying too much activity to the system? Is their system able to tolerate what I'm doing and use it as a gauge for how healthy their system is, right? This is also a system that gets a lot of publicity, and I will say has very poor understanding. Um, and I'll talk about it really quickly in this way, and we'll go much deeper in full classes. I mean, we're doing a 1 hour here. This is a full 15 hours worth of material when you really kind of dive into this. We hear a lot about fight or flight and rest and digest, and we hear sympathetic nervous system and we hear parasympathetic nervous system. Sympathetic being that fight or flight, parasympathetic being that rest or digest. One of the things that really bugs me is a term known as sympathetic dominance, and it talks about it in the term of the sympathetic nervous system being dominant. And that's not the proper way to really think about that. And this is part of where we're going to start to apply that lens. Your frontal cortex, through areas in your brainstem, inhibits your sympathetic nervous system. There's a few reasons babies are born with a really high heart rate, right? Like a resting heart rate of about 120 in an infant is normal because they haven't developed a prefrontal cortex yet to inhibit that autonomic nervous system. They're also running purely on survival because they don't have a lot of experience yet. They also haven't grown their heart to a certain size. So there's a lot of reasons why the heart rate is higher. But part of it is because they haven't grown a cortical area to cause inhibition of that system yet. And so when we see a higher heart rate in an individual, it's not, or we see them more anxious or more kind of on edge, it's not sympathetic dominance. The better way to look at it is sympathetic escape, because your autonomic nervous system is an automatic system. And your sympathetic nervous system is going to run as the default unless it's checked, right? And so when we talk about the autonomic nervous system, when we really get into this, we'll talk a lot about what's supposed to check that system and what's supposed to allow that system to escape. The other side of this is the parasympathetic nervous system, or the rest, digest, and rebuild portion of this system. And you can't turn on TV in 2025 or turn on social media without seeing a vagal nerve stimulator. And to some extent, I love vagal stimulation. We probably need more of it. However, it should be an active process. Vagal stimulation isn't something you do by strapping an electrode around your neck and just relaxing. That's not the right way to stimulate your vagus system. Your vagal system gets stimulated in normal ways. And so when you do it, when it's an abnormal time to have that stimulated, you can really dysregulate the system. So that again is why we can stimulate the vagal system. But if you stimulate the vagal system and you're still anxious and you're still not doing anything to handle your stress or cause that sympathetic um, inhibition, now you end up stimulating both systems at the same time. And that's not really a recipe for a healthy system in the end of the day. So we've got to be careful with how we look at this system. You might think that and again, this is why I don't like the sympathetic dominance, because you would think that the treatment for sympathetic dominance is just to sit around the house and relax, when sedentary lifestyle or sitting around too much can actually cause that sympathetic escape even more. So we have to have movement-based therapies, and that's a lot of what our programs teach is how to create movement-based therapies to actively inhibit this autonomic nervous system and again, restore function to other areas based on your presentation as well. So as we get into this, we'll go more in depth in deeper classes, but I just wanted to give you some images that kind of show a basic breakdown of the system, right? We've got our central nervous system, which is the brain and spinal cord. Peripheral nervous system is everything outside of the spinal cord. And then your other systems are broken down into different things, right? So somatic, you've got special sensory, visceral information coming in. Again, we'll go much deeper in other courses. This is meant to just be an introduction. Another hierarchical kind of look at this system. Peripheral and central are both broken down into other areas. And we talked about, especially in that central system, we talked about a lot of those for those longitudinal levels of the lesion. In the autonomic system, we've also got to take a look at that as well. Right. So just some images to look at it. Again, some basic understandings here of the system. When we look at what the brain needs to survive, right? It needs three things. It needs oxygen, it needs stimulation, and it needs glucose. And really, you could break that down into two things. It needs fuel and it needs stimulation, and fuel being oxygen and nutrition. But in a bigger arching thing, it needs a lot more than that, right? We need love, we need confirmation, we need energy, we need trust, we need loyalty, we need a lot of things for our brain. Stimulation There's a reason stimulation is actually at the top. Your brain requires stimulation more than it needs oxygen or glucose. And so it needs to be stimulated through movement, through neuronal activation, through that increasing of central integrated state or tone, more than it needs any of the other things, right? So again, if we look at the control system, you have that fight or flight, rest and digest pieces that we've already touched on here, and that will go way more in depth in other parts of this with too. But again, just giving you guys kind of an overview of where it goes. This is something too that I want to really spend a second on. Because your autonomic nervous system has effects on all of these areas. If it looks at the heart, the lungs, digestion, even cognition, they have different effects. So the sympathetic nervous system is going to do things like increase heart rate. Sympathetic nervous system is going to cause rapid, shallow breathing. It's also going to cause bronchodilation, where things get bigger. It's going to cause dilation of the pupils. These are all things that will go into how to measure this properly, but it's going to have a decrease in digestive effects. So it's going to decrease your mucosal linings. It's going to decrease things like pancreatic enzymes. It's going to decrease stomach acid production in the gut. So the interesting way to think about this is what happens to blood flow when this happens, right? So these last two, digestion and cognition, when you go into sympathetics, blood flow goes from the inside out in the body. So it goes from your core to your fingers and your toes because you need to run away or you need to fight. The opposite thing happens in the brain. It goes from the outer areas where we do cognition, like thinking and learning, and it goes deep within and it does things like survival. So we're not making memories, we're not able to do math, we're not able to remember what we're supposed to remember in school when we're stressed out. We're more worried about what's going to happen if we fail the test, right? And the same thing happens for digestion. If we're running from a threat, we're not digesting a cheeseburger at the same time. So again, we'll teach you guys how to measure all of these things. It also has effects on things like mood and balance and effects on life, right? So when we have stress, overall, it's going to change the way our cerebellum functions. It's going to decrease cerebellar function. So we have less balance, we have less coordination. It's better for gross motor skills because, again, we need to run and fight, but doing fine motor things like writing or putting pieces together is not necessarily going to be a good thing, right? So it has an effect on everything. And again, another chart that I want you guys to be familiar with, because as we go through the different understanding of sympathetic and parasympathetic and how it affects all of these areas, we need to be masters of this. Because as we're evaluating people and their function, we need to know if we're pushing their system too hard. When we apply therapies, if you see a really big increase in sympathetic activity, that means you're losing the control of that sympathetic nervous system. That means you're exceeding the metabolic capacity of the brain. And what that means is if you adjust somebody and they start sweating and their pupils blow out, you might have put too much stimulation into them. So we might need to make sure we use a lighter force adjustment on them in the future or do something else to adjust their nervous system, so to speak. Right. And we'll get really far into this. We'll also get really far into this aspect with the HPA axis. So we talk about the brain and the spinal cord and the nerves and how that all affects the system. And that's the electrical control. The HPA axis, the hypothalamus, the pituitary, and the adrenals are how we chemically affect the brain and nervous system and the body, right? So this in a sense is your endocrine nervous system that affects everything through chemical means, through hormonal pathways, and through those types of things. And we can go, this is another whole, 300-hour program just on pretty much just on the hypothalamus, the pituitary, the adrenal glands, and all of the chemical messengers that are released as a result of this system. We'll touch on pieces that we need to understand the physiology. But I love to understand some other aspects of this, right? When we look at the effects that cortisol has, again, this is that sympathetic escape, too much stress in the system. We can have things like weight gain, mood swings, anxiety, fatigue, increased in urination, fertility problems, problems with libido in males, infections, more infections, especially things like respiratory infections become much more common. increases in blood flow. You get increases in acne because of hormonal instabilities with things like testosterone and estrogen. You get a loss of bone mineral density. So things when you have too much stress later in life can show up as osteopenia and osteoporosis. You get more muscle aches and pains, which ultimately then becomes things like fibromyalgia, which is related to that loss of bone density because you're actually pulling calcium. And you can even get things like excessive thirst. Um, when the system gets out of balance, you're going to have all of those chemicals running in different ways. And we'll go really far down the rabbit hole with different parts of the program as we talk through those different things. I want to kind of finish on this part here in what we refer to as autonomic balance. Oftentimes, when we talk about the autonomic nervous system, we think that it should be 50-50. It's not even close. You should actually be 80% in your parasympathetic nervous system and only 20% in your sympathetic nervous system. And I would argue that most of us are probably 50-50, or maybe even skewing the other way and having more sympathetic escape than we do parasympathetic tone, or what's referred to as vagal tone. So when we look at different programs, we really need to look at how are we doing with that balance. But when we say the term balance, we don't mean 50-50. We mean this 80-20. And as we go through different therapeutic interventions, as we talk about different ways to affect the system, we'll talk about different breathing activities that put you a little closer to 80-20, right? Your breath shouldn't be short and shallow. We know that. But what is the proper breath? And as we go deeper into things like autonomics, and we go into cerebellum, and we go into these other things in other lectures, we can talk more in depth about what true balance of that autonomic nervous system is. And what the research supports is really an 80-20 balance, but then really how to get there. How do we set our life up for that? How do we set our patient's life up for that, especially if they're dealing with a pathology or they're dealing with something really serious and really troubling? You really need to shift them into that 80-20 because they've got to be way into the rest, digest, and rebuild portion of their system. So we need to be more anabolic is going to be your parasympathetic, and your sympathetic system is going to be catabolic because it's going to burn through energy, it's going to break down tissues, it's going to try to run the system really fast. So we don't want to be burning and breaking down nearly as much as we want to be rebuilding and resting and regenerating. And then this gets into our longevity medicine and things like that too. You can use the nervous system to prolong life, improving physiology, and hopefully lengthen people's lives, right? Our bodies are meant to live over 100, yet our life expectancy seems to keep decreasing every year we go. And now I think in the United States, it's below 70 for males, which is a problem. We're 30 years short of, at least 30 years short of where our bodies were kind of geared towards and really meant to run to. So hopefully this understanding of the autonomic nervous system, we maybe shifted it a little bit. Again, the big key takeaways from this, I think when you look at autonomics, if you're just kind of getting started in this understanding of brain-based chiropractic or how do I leverage the nervous system for health and well-being and vitality and longevity, look at the sympathetic nervous system not as dominant, but look at it as escaping because you've got a lot of cortical areas that are actually meant to inhibit or suppress that sympathetic nervous system. That's why babies are born really heart rate dominant, right? They're really high heart rate early on. They're very sympathetic early on. Once they get up, they start walking around, they start to grow a cerebellum, they grow a prefrontal cortex. They really start to control that autonomic nervous system. And then you see the heart rate come down. Right. And so if we look at just that sympathetic from a sympathetic dominance to a sympathetic escape, I think that thought process alone starts to shift your understanding of the autonomics. And the other part of it is simple vagal nerve stimulation doesn't get us where we need to be because unless we do something that, again, helps to gate or inhibit that sympathetic nervous system or removes the triggers that are causing that sympathetic system to escape, i.e., subluxation or any interference in the system. Now you're just driving the parasympathetic and the sympathetic. Because something I want you guys to understand is simply activating the vagus nerve does not shut down the sympathetic nervous system. The vagus nerve is stronger and it will lower heart rate. It doesn't mean your autonomic nervous system has come back into balance. So and you'll see this in patients all the time if they've got those vagal nerve stimulators or they're doing something passive to activate their vagus system, you'll see escapes in other areas of that autonomic nervous system. You'll see a lot of digestion problems. You'll see cortisol rhythms getting really far off, even though they have a low heart rate. So you can see people that will train themselves into basically an autonomic dysfunction or a dysautonomia because they've been training their vagal nerve when they haven't been doing anything for their prefrontal cortex to inhibit the sympathetic system at the same time. So, and again, with all of the vagal nerve stimulators out there and all these electronic passive devices for it, I think we're going to start to see a whole bunch more of this because you're seeing that be so prevalent. And then you're seeing a lot more people using nicotine patches to treat everything from a hangnail to Alzheimer's disease and cancer. Not that nicotine is, I mean, it's not a great thing. It's a drug, right? It's going to drive the system. But where you got to be really careful is both your sympathetic and your parasympathetic are activated by nicotine. They both run on nicotinic receptors or acetylcholine. Acetylcholine is essentially what nicotine is. And so if you just flood the system with acetylcholine or nicotine, you're going to feel really good. It feels really good when you smoke a cigarette. It also, from what I've heard, feels really good when you take ecstasy or take cocaine, but it also drives dopamine up. It drives the addictive nature. It messes with your reward centers and it messes with other neurohormones and neurotransmitters. So we got to be really careful with these vagal nerve stimulators and treating everything under the sun with nicotine patches because you're essentially going to drive both of those systems at the same time, which is going to cause those systems to get really dysregulated. It's kind of like the boy who called wolf, right? If you keep firing the vagus system when it's inappropriate time to fire that vagal system, when you should be having sympathetic be dominant, the vagal system is going to stop responding. And you can run things into the ground really quickly when you force them into activation when the system isn't ready to activate. So hopefully, this is a good help with understanding the basic level of the autonomic nervous system. Follow me for more. We'll go way more in depth into this system as we unroll things in the 100-hour program and other programs. We'll take a deep dive into this system because it's a really important system to be able to thoroughly understand, test, and then use therapeutically as well. Hopefully, you guys enjoyed this. See you next time.